All right, we are standing right in the middle of a high-stakes, incredibly fast-moving environment, the Emergency Department Trauma Bay. This is the third and final explainer in our Vestibular Emergency series, bringing together the brilliant protocols from Australian Dizziness Clinics. We've already tackled the vascular, metabolic, and toxic threats. Today, we're bringing it all together, and we are bringing it all home.
Listen to this reality check for a second. The first dose of IV ceftriaxone goes in before the radiology phone call ends. That is the absolute level of urgency we're talking about today. In a busy ED, when you're managing highly suspicious dizzy patients, hesitation can literally cost a patient their hearing or even their life.
So the crucial point is, we are looking at three final diagnoses today: bacterial labyrinthitis, bacterial meningitis, and temporal bone fractures. And they all share one terrifying signature, which is rapid decompensation. These conditions just do not give you the luxury of time. If missed, they share shockingly fast path to absolute catastrophe. Here's our roadmap for today. 1. Time-critical bacterial labyrinthitis. 2. Meningitis and the brain. 3. Traumatic temporal bone fractures. 4. The unified ED disposition pathway. And 5. Our series wrap. Section 1. Time-critical bacterial labyrinthitis. Rapid progression. You really have to actively look for this specific clinical pattern. A patient comes in with severe vertigo, but wait, actually look closer. They also have sudden sensory neural hearing loss, ear pain, a fever, and systemic toxicity. I know the waiting room is packed, and it's so easy to get tunnel vision, but this pattern recognition is vital. Do not mistake this for a severe case of benign vestibular neuritis. The systemic signs and the hearing loss, they're screaming that something much more destructive is happening. The action workflow here is incredibly strict. Step 1, draw blood cultures immediately. Step 2, push IV ceftriaxone 2 grams twice daily straight away. You need that broad spectrum coverage to hit Streptococcus pneumoniae and Haemophilus influenzae hard and fast. Step 3, get an urgent ENT review, because if source control fails, the patient might need an emergency mastoidectomy or even a labyrinthectomy. And this brilliantly illustrates our retro print pearl: complications progress to meningitis or permanent deafness within hours. The reality is brutal. Delaying treatment by even a single shift doesn't just prolong their dizziness. It permanently costs the patient their hearing or allows the infection to breach the brain. Aggressive source control is literally your only option here. Section 2. Meningitis and the brain, the lethal masquerader. Okay, this is where your red flag radar needs to be perfectly tuned. The clinical pattern includes fever, headache, neck stiffness, and photophobia, all masquerading behind acute vertigo. As a clinician, you must actively hunt for these systemic meningeal signs in any dizzy patient. If they've got vertigo plus a fever and headache, your differential diagnosis has to shift right then and there. Your rapid response sequence must be flawless. Number 1, empirical IV ceftriaxone 2 grams twice daily plus vancomycin to cover potential penicillin resistance. Number 2, IV dexamethasone 10 milligrams. You got to give that with or before the first antibiotic dose to reduce severe neurological sequelae. And number 3, neuroimaging, followed immediately by a lumbar puncture. Here is an absolute non-negotiable. Never delay antibiotics for imaging or a lumbar puncture. I literally cannot stress this enough. If you suspect meningitis in that dizzy patient, the antibiotics must flow immediately. Delays directly and measurably increase mortality. Treat first, scan second. Period. Section 3. Traumatic temporal bone fractures, post-trauma vertigo. The unmistakable signs of a temporal bone fracture require a really sharp physical exam. You're looking for post-trauma vertigo, obviously, but also hematimpanum, which is blood pooling behind the eardrum. Check for CSF otorrhea leaking from the ear, a new facial nerve palsy, or battle sign, that dark bruising right over the mastoid. A new dizziness presentation in a trauma patient demands a deliberate, focused search for these exact physical clues. So let's see how this builds into our imaging strategy. High-resolution CT of the temporal bones is the absolute gold standard here to identify specific fracture lines. And it's super important to note that otic-capsule-violating patterns carry the absolute highest risk for permanent sensory neural hearing loss and facial nerve injury. You need to know exactly what delicate structures that fracture line has crossed. Now, while you're getting ENT on the phone, the management protocol is mostly conservative. Strict bed rest, vestibular rehab down the line, and really close observation. However, surgical exploration becomes absolutely necessary if the patient develops specific complications, like a perilymph fistula, a persistent CSF leak, or a progressive facial palsy that needs immediate nerve decompression.
Section 4, the Unified ED Disposition Pathway, the anchor. Okay, let's dive into this. This flowchart is the ultimate anchor, the ED red flag imaging decision pathway. The presence of any single red flag instantly pivots your acute or subacute dizzy patient away from the standard peripheral pathway and directly into the vascular and life-threatening category. It's designed to completely streamline your decision-making when you're under immense pressure.
It all boils down to this single rule: dizziness plus any of the following: depressed GCS, focal neurological signs, severe headache, ataxia, which is the absolute inability to stand unaided, acute sensory neural hearing loss, fever, or new neck pain. If your patient has dizziness and even one of these features, it completely mandates a CT scan and a neurology or neurosurgery review before they are ever discharged. No exceptions. Now, what's really interesting about this slide is the massive caveat hiding in this workflow. A normal CT does not rule out a posterior circulation stroke. If your suspicion persists, you absolutely must proceed to an MRI DWI. This is where so many clinicians get caught. A negative non-contrast CT is not a free pass home. It primarily rules out a bleed, not an early posterior infarct. Section 5. Takeaways and series wrap. Just look at the journey we've taken across these three explainers to arrive at this unified understanding. We started off in Part 1 with the immediate vascular killers, the strokes and hemorrhages. Part 2 took us through those really deceptive metabolic and toxic traps. And today, Part 3 brought us through infection, trauma, and finally, the unified ED pathway. Let's consolidate today's session into 3 hard-hitting key takeaways. 1. Empirical antibiotics save the cortex and the cochlea. Do not delay them. 2. High-resolution CT finds the temporal bone fracture. Look carefully for those otic-capsule violations. 3. The unified red flag rule catches the rest. If there is a red flag, escalate immediately. I want to leave you with this final authoritative thought. A small fraction of dizzy patients carry catastrophic diagnoses. Structured red flag recognition, not exhaustive testing, separates a rescue from a miss. It's not about just throwing every test on the board at them. It's about looking for the right clinical signals and acting decisively when you see them. Thank you for watching this series. To explore more similar topics regarding dizziness, vertigo, and imbalance, and to access clinician and patient resource materials, visit AustralianDizzinessClinics.com. Please subscribe and leave a rating.